Welcome back to the deep dive. If you've ever managed a patient dealing with something like heart failure or maybe uncontrolled high blood pressure, the stakes are just incredibly high. So today we're deep diving into a really essential class of drugs that helps manage those stakes. Diuretics.
That's right. These are some real heavy lifters in pharmacology.
Yeah, they speed up how fast urine is formed, essentially pushing the kidney to flush out sodium and, really importantly, water from the body.
Mm-hmm.
And it's kind of amazing, isn't it? We still rely heavily on this class. I read it was discovered almost by accident, something about a mercury antibiotic having a diuretic side effect.
That's the story, yeah. An accidental discovery. And there's still first-line treatments because they're, well, cost-effective generally.
But, and this is the tricky part, they demand absolute precision, especially when you think about managing the electrolyte loss that comes with them.
Exactly. And to really get a handle on diuretics, you absolutely have to understand the, let's call it the plumbing system they work on. We're diving into the kidney's functional unit, the nephron.
Okay.
Think of it like a super complex filtration and recycling plant. If you know the map of the nephron, you basically know how potent each diuretic is going to be and where it works.
Right.
So our mission today is really to follow the flow of that filtered fluid. We start with something called the glomerular filtration rate, or GFR. That's just a measure of how fast the kidneys are filtering blood. And diuretics, fundamentally, they work by interrupting the little pumps, the active transport systems that try to pull sodium and water back into the body along different parts of that nephron tube.
Okay, let's map out that territory then. You said the map is key. So the journey starts at the glomerulus. That's the initial filtering spot.
Correct, step one.
And then everything flows into the proximal convoluted tubule.
Yep.
Now, this proximal tubule, you described it as the recycling engine. It pulls back something like 60% to 70% of all the sodium and water. That sounds huge.
It is huge, and it takes a massive amount of energy for the body to do that.
Okay. Then next, it drops down into the loop of Henle, specifically the ascending limb part.
The thick ascending limb, yeah. That's where another, say, 20% to 25% of sodium and chloride get recaptured.
Gotcha. And then the last bit, the distal convoluted tubule and the collecting duct, they handle the final, 5% to 10%, the fine-tuning.
Exactly. And that final adjustment is partly controlled by a hormone called aldosterone. We'll come back to that.
Okay.
So the big takeaway from this map, the potency of a diuretic is tied directly to where it works.
How so?
Well, the earlier in the nephron a drug acts, the more sodium and water it blocks from being reabsorbed downstream. Simple as that. More blockade earlier means a stronger diuretic effect overall.
Okay, but here's something I was wondering about from the source material. If that proximal tubule handles, you said, up to 70% of the reabsorption, why isn't the drug that works there the most potent one?
Ah, that's a fantastic question.
Let's start with that group then. The carbonic anhydrase inhibitors, or CAIs, like acetazolamide.
Acetazolamide is the main one, yes. And you're right, they work primarily in that proximal tubule, but they aren't the heavy hitters. It really speaks to the kidney's amazing ability to compensate later on, downstream. CAIs are effective initially, but the nephron adjusts.
Okay, so how do they work? The mechanism.
It's pretty elegant, actually. They inhibit an enzyme called carbonic anhydrase. Now, you don't need to get lost in the chemistry, but basically, this enzyme helps create the fuel needed for a specific pump that pulls sodium back into the blood.
Right.
CAIs shut down that fuel source so the pump stops. Sodium and water stay in the tubule and get flushed out.
What's interesting about acetazolamide, though, is its main uses aren't really for, massive fluid overload, are they? It's used for glaucoma.
To increase aqueous humor outflow.
And for altitude sickness.
Yeah.
Managing the headaches and dizziness.
Exactly. Specialized uses. But you don't typically see them used long-term for heart failure, for instance.
And why is that again?
Because their diuretic punch fades pretty quickly, usually after just 2 to 4 days. And the main reason is they cause something called metabolic acidosis. They disrupt the body's acid-base balance, making the blood slightly more acidic. The body then tries to correct that, which counteracts the drug's effect.
Got it. And a safety point for our listeners.
Oh, definitely. CAIs can raise blood glucose levels, so if you have a patient with diabetes, they need to be extra watchful with their sugar monitoring.
Good to know. Okay, so we've done the, let's say, specialized, milder group. Let's move to the real powerhouses. You called CAIs a garden hose, so are the loop diuretics the fire hose?
Huh. That's a pretty good analogy, actually.
Yeah.
When we talk about furosemide Lasix is the common brand name or its relatives like bumetanide and torsemide, we are absolutely talking crisis management. Big guns.
And why are they so potent? Where do they work?
They hit that sweet spot, the thick ascending limb of the loop of Henle. Remember, that's where 20–25% of sodium and chloride get reabsorbed. They block that effectively.
Okay.
But furosemide in particular has a sort of double action, which makes it vital in acute heart failure situations.
Oh, what's the second action?
Well, besides making you lose water, loop diuretics also trigger the release of renal prostaglandins. And these prostaglandins cause blood vessels to relax, to vasodilate,
Ah, okay.
so that immediately reduces systemic vascular resistance. It lessens the workload, the preload, and central venous pressure on a heart that might be struggling. It's both a diuretic and it provides immediate cardiovascular relief.
Wow. And that speed you mentioned of furosemide kicks in, what, 5 minutes?
About 5 minutes, yes. It's incredibly rapid. And here's another crucial point. They keep working even if kidney function is pretty poor.
Unlike other types.
Unlike most others, yes. Even if the creatinine clearance, a measure of kidney function, drops below 25 milliln, loops still have an effect. That's huge for patients with kidney impairment.
But that kind of power must come with significant risks, right?
Yeah.
Adverse effects.
Absolutely. The main concern is massive electrolyte loss. Hypokalemia low potassium is the biggest worry. It can be severe and often needs aggressive potassium replacement. And furosemide actually carries a black box warning specifically about this risk of profound fluid and electrolyte depletion.
And wasn't there something about hearing loss, too? Ototoxicity.
Yes, that's a rare but serious risk, especially with prolonged use or very high doses. Patients might experience hearing impairment or tinnitus, ringing in the ears.
And interactions. What should we watch out for?
Big ones here. Combining loop diuretics with other drugs that can harm the nerves or ears, like aminoglycoside antibiotics or vancomycin, increases that neurotoxicity and ototoxicity risk.
Okay.
And crucially, if your patient is also taking digoxin, a heart medication, the hypokalemia caused by the loop diuretic drastically increases the risk of digoxin toxicity. That can lead to really dangerous heart rhythm problems.
Serious stuff.
Yeah.
Okay, so we've got the fire hose for heart crises. But what if the fluid problem isn't heart failure edema, but maybe pressure inside the head? That sounds like it needs a different approach.
It absolutely does. And that's where the osmotic diuretics come in. Mannitol's the classic example here.
Mannitol. How does that one work? It sounds different.
It's totally unique. Mannitol is what we call a non-absorbable solute. It basically stays inside the nephron tubule as it travels along, mostly in the proximal tubule and the descending loop.
And what does it do there?
It acts like a big osmotic sponge. Because it's stuck in the tubule, it increases the concentration, the osmotic pressure, inside the filtrate. This pulls water out of the surrounding tissues, including the brain, and into the tubule by osmosis.
So it draws fluid out differently, not by blocking sodium directly.
Exactly. It causes rapid diuresis, a lot of urine output, but with relatively little electrolyte loss compared to the loops.
So where would you use mannitol then?
Primarily for situations where you need to reduce fluid volume in specific compartments fast. Think reducing dangerously high intracranial pressure or swelling in the brain, maybe after a head injury, or sometimes for high pressure inside the eye.
Okay, but not for typical swelling, like in the legs. Peripheral edema.
Generally, no, because it doesn't promote enough sodium excretion to be effective for that kind of systemic edema.
And clinically, mannitol's a bit unusual too, right? FOV only, and something about a filter.
Yes, always FI, and critically, it must be given through a filter. The reason is mannitol can crystallize out of solution, especially at cooler temperatures or if the concentration is high.
Wow.
So vials are often kept in a warmer. You might literally need to warm up the drug before you can safely infuse it, and the filter catches any crystals that might have formed.
Fascinating. Okay, so we've gone from crisis management to this specialized osmotic pull. Let's shift gears now towards maybe maintenance therapy and balancing things out. We're moving down the nephron now.
Exactly. We're heading towards the end of the line, the collecting ducts and distal convoluted tubules. This is where the potassium-sparing diuretics do their work. Think of drugs like spironolactone, triamterene, and amiloride.
Potassium-sparing, the name says it all, right?
It does. Their main job, or benefit, is that they help the body hold on to potassium, unlike the loops and thiazides we'll discuss next.
How do they work? Spironolactone is the main one.
Spironolactone is probably the most common. It works by blocking the effects of that hormone we mentioned earlier, aldosterone.
Okay.
Aldosterone normally tells the kidneys to save sodium and water and get rid of potassium. Spironolactone blocks aldosterone's receptor, so sodium and water get excreted and potassium stays in.
And the others, triamterene and amiloride.
They work a bit differently, more directly on the sodium channels in that part of the nephron, but the end result is similar. Sodium out, potassium stays.
Are they strong diuretics on their own?
Not really, no. They're considered relatively weak diuretics. Their real value often comes when they're used with other diuretics.
Ah, like in combination.
Exactly.
Okay.
Especially combined with thiazide diuretics. This gives you a stronger overall diuretic effect, but crucially, the potassium-sparing drug helps counteract the potassium loss caused by the thiazide. It's a balancing act.
Makes sense. Get the fluid off without tanking the potassium levels.
Precisely. And spironolactone has another interesting benefit, particularly in heart failure.
Hmm.
Its anti-aldosterone effect seems to provide some direct cardio protection. It helps prevent harmful changes or remodeling in the heart muscle that can happen after heart attacks or with chronic heart failure.
Okay, that's a significant plus. But if the loops cause low potassium, these must cause the opposite problem.
You got it. The major concern with potassium-sparing diuretics is hyperkalemia, high potassium levels. We usually define that as a serum potassium over 5.5 millieql.
And that's dangerous.
Potentially very dangerous, yes, especially for the heart. The risk goes way up if these drugs are combined with other things that raise potassium, like ACE inhibitors or even just potassium supplements.
Okay, need to be careful there. Any other side effects? I think spironolactone had some odd ones.
It can have some endocrine-related side effects, yeah.
Mhm.
Because it interacts with hormone receptors, it can sometimes cause things like gynecomastia, breast enlargement in men, or irregular periods in women.
Right. Okay. So that brings us neatly to their typical partner drug class. The thiazides and thiazide-like diuretics. Hydrochlorothiazide, HCTZ, is the big one here.
HCTZ is the prototype, absolutely. And then you have related drugs like metolazone. These are the real workhorses for managing chronic conditions like hypertension.
Where do they work in our nephron map?
Their main site of action is the distal convoluted tubule. They block the reabsorption of sodium, potassium, and chloride there.
Okay, so further down the line than loops. Less
Yeah.
potent, maybe?
Generally less potent than loops, yes. But they have a key advantage for long-term hypertension management.
Which is?
Besides the diuretic effect, they also cause direct relaxation of the arterioles, the small blood vessels. This reduces peripheral vascular resistance or afterload, which directly helps lower blood pressure. It's that dual mechanism again.
Nice. But I remember reading a limitation with these, something about kidney function.
Yes, a big one. Unlike the loops, the effectiveness of most thiazides drops off sharply as kidney function declines. Once the creatinine clearance gets below about 30 to 50 milliman, they don't work nearly as well.
But there was an exception.
Metolazone, that's the important exception. It seems to remain effective even when the GFR is quite low, down to around 10 milliman, so it can sometimes be used in patients with more significant kidney disease.
Good distinction. And HCTZ specifically had something called the ceiling effect.
That's right, a very important concept. There's a maximum dose, usually around 50 milligrams per day for HCTC, beyond which you don't really get much more diuretic effect.
You just get more side effects.
Exactly. Increasing the dose further mainly just increases the risk of adverse effects. And speaking of those, besides the expected hypokalemia, thiazides are kind of notorious for causing metabolic disturbances.
Like what?
They can increase blood sugar levels, hyperglycemia. They can raise uric acid levels, hyperuricemia, which is bad for gout. And they can elevate lipid levels, hyperlipidemia.
Wow, okay, so lots to monitor there. Which brings us perfectly to the practical side, the nursing process. Knowing the drugs is one thing, but managing the patient safely, that's the real core, isn't it?
It absolutely is. Assessment has to be ongoing, vigilant. We need daily weights, same time, same scale, same clothes. Strict intake and output, monitoring.
And checking blood pressure. Orthostatics.
Crucial. You have to check orthostatic vital signs. Look for that drop in blood pressure, maybe 20 millimol Hg systolic or more, when the patient goes from lying or sitting to standing. That's a huge red flag for dehydration or excessive fluid loss and a major fall risk.
Right. And labs, obviously.
Non-negotiable. You're monitoring serum potassium like a hawk, but also sodium, chloride, magnesium, calcium, uric acid, and of course tracking kidney function with creatinine and BUN.
And any special assessments for specific drugs?
Yeah, a couple. With torsemide, one of the loops, you need to be aware of the rare risk of Stevens-Johnson syndrome, a severe skin reaction. And with loops in general, remember that ototoxicity risk, asking about hearing changes or tinnitus.
Okay. And then implementation. How do we make sure patients take these safely? The timing seems critical.
Absolutely critical. Diuretics must be taken in the morning.
Why? To avoid nighttime bathroom trips.
Exactly. Taking them later in the day leads to nocturia, having to get up frequently at night to urinate. This significantly increases the risk of falls, confusion, and injury, especially in older adults. Morning dosing is a key safety measure.
Makes sense. And getting up slowly.
Yes, reinforce that constantly. Teach patients to change positions, slowly sit on the edge of the bed for a minute before standing to minimize that risk of dizziness from orthostatic hypotension.
Okay. And the big one, potassium. How do we teach patients about managing that? It seems confusing with some drugs wasting it and others saving it.
We have to simplify it. It boils down to a clear binary choice based on their specific diuretic.
Okay.
If the patient is on a potassium-wasting diuretic like a loop or a thiazide, you actively teach them to increase their intake of potassium-rich foods. Think bananas, oranges, potatoes, tomatoes, leafy greens.
Got it. Eat more potassium.
Unless they are taking a potassium-sparing diuretic. In that case, they must do the opposite. They need to avoid excessive potassium-rich foods and definitely avoid potassium supplements because the risk is hyperkalemia.
Okay, so it's either eat potassium or avoid potassium, depending on the drug. Clear distinction.
Very clear. And they need to know the warning signs for both problems.
What should they look out for?
For hypokalemia, low potassium, things like muscle weakness, lethargy, maybe confusion, anorexia. For hyperkalemia, high potassium, which is often the bigger cardiac worry symptoms, might include nausea, vomiting, diarrhea, muscle cramps, and potentially serious heart rhythm changes. They need to report those symptoms immediately.
Right, that's crucial teaching. So just to recap quickly, we've walked through the 5 main classes. The CAIs, the powerful loops, the specialized osmotics, the balancing potassium-sparing ones, and the workhorse thiazides. And we kept coming back to how their power and their effects are directly linked to where they act along that nephron pathway.
Exactly. The map dictates the mechanism and the potency.
So a final thought for our listeners.
Yeah.
What's the big takeaway message here?
I think the critical thing to understand, especially for you as learners and future practitioners, is the inherent tension within this drug class. The goal is always a delicate balance.
How so?
Well, think about it. A drug powerful enough to manage severe heart failure, like a loop diuretic, carries the inherent risk of causing dangerous, even life-threatening electrolyte imbalances that can also affect the heart.
Right. Power versus safety.
Precisely. And that tension highlights why your role, your vigilant assessment, your careful monitoring, your clear patient teaching is absolutely the most vital part of making diuretic therapy safe and effective. It's all about managing that balance.
That's a perfect place to leave it. Thanks so much for breaking that all down for us. And thanks to all of you for joining us for this deep dive into diuretic pharmacology.
And a warm thank you from the Last Minute Lecture team.